How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, we're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Hi, you're watching DNA Today, a multi-award-winning genetics podcast where we explore everything to do with genetics, from CRISPR to rare diseases to new research. We have won the Science and Medicine Podcast Award for many years now. We have hundreds of episodes, and we really hope you enjoy these conversations where we dive into so many genetic concepts. I'm Kira Dineen, a certified genetic counselor, and your host. Hi, you're listening to It Happened to Me, a rare disease and medical challenges podcast. The mission of our podcast is to support you, our listeners, and to create community as you confront the toughest challenges in life. All of us will experience health hardships. The real question is how we adapt. That's the focus of It Happened to Me, which wants to help you overcome limitations and live a full and satisfying life. Drawing on their own health challenges, co-hosts Cathy, Gildenhorn, and Beth Glassman interview guests who share stories and research to help you succeed in the face of difficult health obstacles. It happened to me. I'm not alone, and neither are you.
We are honored to have Dr. Andrew Carey on It Happened to Me today. I must disclose, Dr. Carey is my doctor and my hero. He is the doctor who diagnosed my rare disease, Wolfram syndrome. Dr. Carey is a neuro-ophthalmologist and an assistant professor of ophthalmology in the Division of Neuro-Ophthalmology at the Wilmer Eye Institute.
Dr. Carey specializes in neuro-ophthalmic disorders, as well as diseases of the retina, including age-related macular degeneration, diabetic retinopathy, toxic retinopathies, and inherited disorders of the retina.
So many specialties in your repertoire, Dr. Carey, but today we will focus on neuro-ophthalmology, optic neuropathies, and rare disease. Let's start at the beginning. What is neuro-ophthalmology, and how do you know when you need to, pardon the pun, see one?
Well, hi, Cathy and Beth. Thank you so much for inviting me on here. It's such a pleasure to talk with you guys today. Neuro-ophthalmology is the subspecialty of ophthalmology and neurology, kind of the intersection of the two, that deals with disorders involving the connection between the brain and the eyes. Most people probably don't know this, but 40% of your brain is actually dedicated to vision, whether it's the interpretation of vision, capturing the light, or helping to control eye movements. And so that's a lot of neurologic real estate. And neurologic conditions can cause loss of your side vision, decreased central vision, problems interpreting the world that's around you, even if your eyes can capture all of that, as well as causing double vision, where you're seeing two of things, drooping of an eyelid, or shaky vision, where your eyes aren't stable and the whole world looks like it's moving or spinning, even though you're perfectly still. And most of the time patients are referred to me, they're referred by a doctor who has some kind of concern about their medical health, and that it may either affect their vision or their neurologic function related to vision. And probably most of my referrals come from other eye doctors, either optometrists or optometrists or ophthalmologists, who saw the patient who had some kind of vision complaint and identifies that it's not really a problem with the eyeball itself, and then we'll refer it to the neuro-ophthalmologist. They may come from a neurosurgeon who is seeing a patient for some type of brain tumor that is near or involving one of the vision centers or the vision pathways in the brain. Sometimes we get referrals from the endocrinologist because the patients have a disorder with hyperactive thyroid, and that can impact the eyes and vision. Sometimes we get referrals from endocrinologists because they're found to have a growth in the pituitary tumor that regulates all their hormones and metabolism, and that is very near to the vision nerves. And that's probably most of the time how patients will end up coming to see me. Sometimes they'll be referred from a neurologist after a stroke, or if they have
I was
multiple
going to ask that.
sclerosis
Yes.
would be the other common times. And occasionally there'll be a patient who is doesn't feel satisfied with the care or evaluations they've had before, and they'll read about their symptoms online, either
Yeah.
from an education site or a patient support, group support site. And they'll say, I had symptoms like that, and I went to go see this kind of doctor, and maybe you should think about doing that. And so sometimes it's a patient who advocates for themselves.
Wow, that's
But you see
fascinating.
these are very serious illnesses. People are very
Potentially,
sick.
sometimes they're benign things like migraine, which happens in 1 in 7 people in the world, and 1 in 3
Yes.
people with migraines will at some point have some kind of vision symptom.
Huh.
Classically, it's seeing flashing lights or funny colors like a kaleidoscope, and sometimes it's a
Oh,
blackout in vision. And
oh,
most of the time, that's not serious, but it could be something serious, and so you want to see somebody who is familiar with it to kind of distinguish what's going on. Some causes of double vision are self-resolving, but it's not something that's quite apparent to the patient, and it could be something serious like a stroke or a brain tumor or multiple sclerosis. So
Fascinating.
that's why we have specialists.
Well,
oh.
yeah. Can many rare diseases be diagnosed via the eyes? And which type of eye doctor should listeners look for, look to see?
There are a number of rare diseases that can be present with eye findings, and any structure of the eye, can have a rare disease impact it, whether it's the eyelids, the cornea, and the surface of the eye, the iris, which is and a very vascular tract in the eye that plainly, is the colored portion that opens and closes to light, and it forms the pupil with the hole in the center. But autoimmune diseases can cause inflammation in that we call uveitis. We can certainly get rare diseases in the retina, genetic diseases, and in the optic nerve, as well as some of the rare diseases can cause eyelid drooping, problems with eye movements, double vision. Um, I think the good news is eye doctors get very comprehensive training, both ophthalmologists and optometrists during their schooling, and if they seek additional education afterwards in the form of a residency or a fellowship. And they really do form kind of the first line of eye
Mhm.
care, kind of like a primary care doctor for your eyes. And because a lot of times patients don't know if they know they'll have a vision problem, but they don't know, is it a retina problem or an optic nerve problem or a
Yes.
cornea
Right.
problem.
Right.
So they go see their local eye doctor who's maybe seen them before and knows what's normal for the patient and what's not normal for the patient. Or if they've never seen an eye doctor, they'll go to a local optometrist or a local ophthalmologist who will do a comprehensive evaluation and at least try to localize what part of the eye the problem is coming from, if not be able to fully diagnose and manage it. And then if they can at least figure out, what part of the eye is the problem, or is it a part of vision outside of the eye, then they can help direct them to the right kind of specialist that they need.
And what should people expect? I know that my wonderful eye doctors thought I had low tension glaucoma for approximately 15 years. And that is glaucoma, one type of optic neuropathy. But I experienced certain symptoms that were atypical of glaucoma, but it wasn't until I was lucky enough to end up in your chair that you recognized my symptoms, while not typical of glaucoma, could indicate Wolfram optic neuropathy. And so you did all the genetic testing and confirmed the diagnosis. Would that be a typical diagnostic journey? Not exact, but something long term and something where it can take a while to manifest itself in a way that makes it more noticeable what it is.
I would say that's definitely not uncommon. Sorry to use the double negative. I think one of the tenets of medicine that we learned during our training is that common things happen commonly, and even an uncommon manifestation of a common disease is much more likely than the typical manifestation of a very rare disease. And to kind of highlight this, they say when you hear hoofbeats, you should think horses and not zebras, perhaps unless you're in the Serengeti. And and so, glaucoma is exceptionally common. 2% of people over age 40 will have glaucoma, and about half of people who have it don't even know they have glaucoma. So when doctors see, an optic nerve that looks enlarged, and we'll often describe it as cupping, where there's a normal dip in the optic nerve, like looking at a cup from head on. And when that center portion, the dip, is enlarged, that's very commonly a sign of glaucoma. And sometimes the early stages of many diseases, mild stages, look very similar, with good central vision, good color vision, and mild peripheral vision damage. And it's not until patients have been followed for a long time or something changes that we say, this doesn't quite fit what I was expecting. And that's a concept that in diagnostics we refer to as keeping an open mind and avoiding what's called premature closure, where you say, oh, I saw this patient 10 years ago, it's glaucoma, no matter what happens, because I said it's glaucoma in my head, I always think everything is just going to be glaucoma. And if you're a glaucoma specialist and all you ever see is glaucoma, it's even harder to stay out of that trap.
Right.
And so, just every once in a while you step back and you say, is this what I'm expecting to see? Does this fit the typical picture? And if not, then we have to think about alternatives. And I think the doctor who had referred you to me, he had looked at you and said, this doesn't look like typical glaucoma that I see, because I see glaucoma every day, and haven't seen anybody else like you today that looks like this, or this week, or this month. So maybe we'll have somebody else who sees things other than glaucoma take a look. And a lot of times that is how things get to me. I mean, and for diseases that are slowly progressive, it's great if we could, the first doctor who sees you, tell you the diagnosis, but um, it's hard, and as long as nothing harmful happened to you in that journey, it's probably okay. For really serious diseases that cause rapid progressive vision loss, probably we'll figure it out a little sooner, because glaucoma is, for most people, very slow. It's a very small percentage of people that lose their vision very quickly from glaucoma, and usually it's pretty obvious.
So, but it is a typical journey towards a diagnosis, not something that you can do on that fast track, except in the more extreme cases where it's really apparent that you need to go.
Absolutely. And sometimes even when I see a patient for the first time and I know it's not glaucoma, it's something different, it takes a few visits to really figure it out, because you need more information.
Told me about Wolfram and told me to, get the genetic testing, and it took me 1 or 2 visits before I actually jumped on it. The same thing. It's a process.
Yeah, and sometimes it takes time to collect information, and sometimes the clinical picture, the symptoms the patient is having, will change over time, and that offers us new clues to help us figure it out.
Dr. Carey, Cathy's journey is unusual, and yet it's not unusual. She was lucky that someone, as you said, was open-minded when they took a look at the retina and said, this just doesn't look right. I thought she had glaucoma. So lucky for Cathy that this doctor really, as you said, kept an open mind and said to her, I'm going to send you to someone else. And how great that this Wilmer doctor had that foresight to open up and ask a colleague to take a look at his patient. I think that shows a great deal of confidence in that doctor. But what Cathy has described is a 15-year journey in finding out that she has a rare disease. And one thing that we have learned on our podcast is that patients seem to go through quite a long journey from doctor to doctor, test to test, to find out really what it is they have. They know there's something wrong and they can't figure it out. Do you find this also to be true with your patients?
Absolutely. I think we all have our own story, or a friend we know who went through, doctor to doctor, lots and lots of visits, trying to figure out what was wrong. And the rarer the disease, the harder it is to to find the right doctor to make the right diagnosis. I think, one of the other things that happens in medical training is when there's an emergency, we kind of try to prioritize what's the thing that's going to be most dangerous to my patient right away and make sure we take care of that because we don't want anything bad to happen to our patients. And then we like to think about what's the most common conditions that are going to present in this manner because we don't want to miss the common things, and common things are common. And so we kind of work our way down. And I think what we find with patients is it's not one doctor doing all of that work and cognitive processes, and it ends up being many doctors. And because some of these conditions are very rare, um, you know, some of the rare things I see are 1 in 10,000 events, and some of them
Mm,
are 1 in 750,000 events.
Hmm.
Wolfram's is 1 in 750,000 people.
mm,
Um, most doctors will go their whole life and never see a case that's 1 in 1 million, and they may never
yeah.
even read about a case, a diagnosis that's 1 in 1 million if it's that kind of rare and it's outside their specialty. So I think, when you talk to patients, that it's a very common experience, to try and improve on that experience, to shorten that journey and improve the efficacy or efficiency of, trying to get patients diagnosed faster and to the right doctors. It probably takes a lot of system changes. I think we need more doctors. Not, I mean, we need more doctors for primary care and common things, certainly, and that would also help to reduce some of the burden um, on the doctors when patients come in with atypical things, that they can take the time to help and focus on that
So,
kind of stuff.
You're
Um,
asking the question that I absolutely wanted to know. How do we shorten this diagnostic journey? And you're saying so more doctors. Um, what else can you think of that might help us shorten the agonizing wait?
yeah, so I certainly think, more doctors in a variety of specialties. Primary care
Yeah,
is important because they do those initial steps. They listen to the
yes.
patients and they help to direct them where they need to go. And then we also need more specialists, or more availability of the specialists. It's not uncommon for it to be 6 months before I can see a new patient, unless somebody
Mm,
calls and says, Dr. Carey, I think this is really urgent. Can you make time in your schedule? Because it's also not uncommon that I'm seeing patients until 6 or 7 o'clock at night,
oh
which
my
is not a
goodness.
fun experience for the patients,
No.
but this is what we do to try and take care of people. Um, and
or
so,
for you.
yeah,
Yeah.
yeah. And I think, one of the few good things that came out of the pandemic is the improvement in telemedicine, and something that we call interprofessional e-consults, where a doctor can say, "Hey, I saw this patient and I did this testing and I'm not really sure what's going on. Can you take a look over all of this and tell me what you think?" And that's something that's now supported by Medicare, where they will recognize the value and the time that a doctor would put into that,
Oh,
because I,
that's
I can
great.
I can do that a lot faster than I can schedule a patient and have them come into the office and have the technician talk to them and do the testing and then spend the time to talk with the patient. At least I can get an idea of what's going on and say, that's urgent. That's something, they don't even need to see me. They need to be in the emergency room. Or I can
Mm,
say, that's something that I could definitely help with. Or I don't think that's something I could help with. Please don't schedule the patient with me and wait 6 months for me to tell you I can't help you with that. Send them to this other doctor. Um, and so I think that's helpful. It's still in early stages, and it's not something that's been universally implemented. And probably there's doctors that don't even know that you can do that yet. Um,
Mhm.
so this collaborative, you're really speaking about working together, doctors crossing maybe cross specialties,
Absolutely.
calling on each other. And I guess it would work well within you're at Johns Hopkins, so the different doctors could call each other within the network, and you can communicate with each other in a very readily, easily way to do.
It's certainly much easier to do it within a single health system where all
Yes.
of the patient information is already in a single system that we could look
Uh-huh.
at and communicate easily. It can be done across systems
Okay.
as well. Um, that's allowed. It takes a little bit more work, but it's not that much different work than how things, you know, were before we had computers, where you had to send a letter and
Right.
records on paper, and the doctor had to look at it. So, it's just a little bit more work than saying, "Hey, I got all this stuff here in the computer already. Can you look at it for me?"
It's amazing how the pandemic has really created some hybrid ways and technical ways of doing things that, wow, we're all thrilled that the pandemic has gone into different directions. I hope some of these technological advances just are continually used and continually improved so that, for instance, using this technique, patients can see a specialist in a more timely manner, in a more worthwhile manner.
Absolutely. We couldn't record this podcast on Zoom before the pandemic.
Right.
Who had Zoom?
That's right.
Now it's like
Right.
Kleenex. It's everywhere. It's
Yes.
just a part of life.
Yes.
It's amazing. Well, I have a question because it seems from everything that you're doing like you're a detective. And I'm just curious, what other conditions do you commonly diagnose?
It's funny you say that. I oftentimes feel like a detective. I think a lot of neuro-ophthalmologists go into neuro-ophthalmology because we get to solve puzzles and do detective work. At my residency graduation, the classes below us get a chance to kind of roast us, and they picked which superhero each one of us would be. And for
Oh.
me, they decided that I was Batman because he's a detective. Um, He's like the Sherlock Holmes of superheroes, and I was so honored that they picked that for me. A lot of the times patients are referred to me with a known diagnosis, and they just need a really good vision evaluation to help with management. Like maybe they have a brain tumor, or maybe they know they have multiple sclerosis, and they want somebody to monitor the neurologic function of vision. Um, but patients who get referred without a diagnosis, and there's in neuro-ophthalmology, we kind of think of two pathways. One is something that's caused vision loss, and we kind of categorize patients as younger, which is under age 50 usually versus older. And in younger patients, vision loss in one eye oftentimes is an inflammation of the optic nerve called optic neuritis. And about half the time that's related to multiple sclerosis, which is an autoimmune inflammation condition of the brain. And
Mm.
optic neuritis may be the first sign of that in about a third of patients.
Oh,
Mm.
wow.
So that's pretty common. In older people, vision loss in one eye is most commonly due to a stroke in the vision nerve called
Mm.
ischemic optic neuropathy. And that can be very devastating to some patients because while it typically will only happen in one eye at a time, about 20% of patients it'll happen in both eyes.
In
And
both.
Oh no.
and while it doesn't often leave them completely blind, the vision impairment often involves the center part of the vision, and it's
Oh.
pretty life altering, which is
So this is a
unfortunate.
stroke in the eye, is what you're
Yep.
talking about, Dr. Carey.
Yeah.
But if you had the stroke in the one eye, would they go on medication to, blood pressure medication? Would that wouldn't relieve the stroke occurring in the other eye?
A stroke in the optic nerve is
Not
complicated. We
really.
certainly try to reduce risk factors and help to work with primary care doctors and cardiologists to make sure blood pressure and cholesterol and blood sugar, like diabetes, is well controlled. It turns out the biggest risk factor for it happening in the second eye is untreated sleep apnea, where people
Oh, for
have
goodness
severe
sake.
snoring and will even stop breathing while they're sleeping. And most of the time, they're not
Ah,
really aware of it, although they
Oh.
may wake up multiple times during the night with a choking sensation, or or just wake up feeling really not well rested and often very sleepy during the day. And if they're lucky, there's somebody else in the room that will say that they've stopped breathing, notice that
oh
they
my
stopped
Oh.
breathing while they're
goodness.
sleeping. Um, uh, and it turns out having that untreated increases the risk by about fourfold and treating
Oh,
it brings it back down.
wow.
And so if they're not diagnosed, we try to get them checked for it and treat it as quickly as possible. Unfortunately, as we were talking about, there's a shortage of doctors. Sometimes it takes a couple months to get the testing and treatment done. And then the really unlucky patients, the second eye happens before that.
Well, what is
My
the
goodness.
difference between this and all the different types of optic neuropathies? What is optic neuropathy and what is the difference?
Yeah, so optic neuropathy means damage or dysfunction of the optic nerve, which is the nerve that carries the message of sight from the eye back to the brain. And depending on how you classify it, there's a number of different causes. Glaucoma being the most common in people over age 40 or 50, which is where there's a pressure mismatch between the pressure inside the eye and the pressure behind the eye in the spinal fluid that causes a pressure gradient across the back of the eye and leads to vision loss, usually peripheral vision,
Mhm.
but it's progressive and works its way in towards the center. The second most common would be ischemic optic neuropathy, which is a problem of blood flow to the vision nerve that most of the time is related to similar vascular risk factors like high blood pressure, diabetes, sleep apnea that we just talked about, but can also be triggered by inflammation in the vision nerve, or not in the vision nerve, inflammation in the blood vessels that causes the blood vessels to close off all of a sudden and vision loss. You can also have inflammatory optic neuropathies, either triggered by some kind of infection or the immune system being overactive and attacking the vision nerve. We can also have disorders of high pressure inside the head, where that pressure is transmitted down across the nerve and kind of pinches and squeezes the nerve due to a buildup of too much spinal fluid. We can also have what's called a compressive optic neuropathy, where something outside the vision nerve is pushing on it, and that causes damage, and that's usually a brain tumor, but could be an abnormal blood vessel like an aneurysm.
Wow.
Or swollen muscles behind the eye related to some kind of inflammation in those muscles. And then we have nutritional or toxic optic neuropathies, where there's some kind of mismatch between a possible toxin like lead or not having enough nutrients like vitamin B12 for the nerve to function normally.
Wow.
And then we have genetic causes, where a gene that's important for the function of the nerve is not working well, and usually that's genes related to energy production or maintaining the stability in the nerve.
So that's what I have with Wolfram optic neuropathy. Huh.
Yeah.
Completely different than
Very different, and they can all present with different symptoms, different progression. They can be one eye or both eyes, painful, not painful, involving center vision versus peripheral vision. And the appearance of the nerve when we look in the eye can be different. Sometimes the nerve is swollen, where it's bulging forward. Sometimes the nerve looks normal early in the disease course of some of these conditions, and sometimes it will be pale, where it loses its nice orange-pink color and turns more of a whitish yellow. And then you can have cupping, which is where the enlargement in the divot of the nerve occurs as a portion of those in some of those conditions. And trying to put all those puzzle pieces together gives you a better idea of what the cause may be and helps guide the direction of investigation.
This is
And
just
the testing
incredible.
is an OCT like you would do in a glaucoma exam. Is that how you see the optic nerve?
We have a variety of tools that we can use to evaluate the optic nerve. The OCT has certainly become indispensable since its invention in the early 2000s. It allows a three-dimensional viewing of the optic nerve and fine detailed. And so the OCT has become really valuable for diagnosis, determining is this a normal nerve or a not normal nerve, as well as following patients over time and seeing what kind of changes are happening to the vision nerve. The OCT is also really helpful for evaluating the retina, because sometimes we can't tell from the exam, or we're talking to the patient, is this a retina problem or an optic nerve problem? And so we can use the OCT to kind of distinguish that. And the other common tools we use to evaluate the function of the optic nerve is the peripheral vision test, often called the visual field, and that gives us a lot of information about how the optic nerve is functioning, as well as the pattern of damage to the vision nerve. Is it mostly the center part of the vision or more of a peripheral vision? We will commonly check the color vision because color vision in a number of optic neuropathies can be affected even more so than central vision, particularly in those inflammatory optic neuropathies. And so that really helps us to determine the type of optic neuropathy, as opposed to in glaucoma. Unless it's really severe glaucoma, color vision should be normal. And in most retinal conditions, the color vision is still very good. But in like an inflammatory optic neuropathy, they can have pretty good vision on the eye chart, but have really severe color vision impairment. And then some other testing that are done outside of the eye clinic, because we can only really look at the part of the optic nerve inside the eye in the eye clinic, which is about a millimeter's worth. But it stretches all the way back towards the brain. So oftentimes we'll need to do neuroimaging, and most commonly that's done with an MRI scan to really evaluate the full length of the optic nerve, as well as the other vision centers in the brain. And sometimes we'll see other clues going on for what the mechanism of injury to the optic nerve is.
Well, it makes me then think kind of the old-fashioned, the narrative, a relationship you have with your doctor. How important is it that you're completely open, detailed, and comprehensive about all your systems with your doctor, even if you think it's something, small and not important, versus something that you're not sure that it's at all related to your visual issue? I'm just wondering if the testing needs to be so big, if the narrative with your doctor needs to be comprehensive.
Absolutely.
How do you know where to draw the lines?
Yeah, I think the first time you see the neuro-ophthalmologist, they want to know anything that is not normal with you, because it really can impact it. I mean, I ask my patients, some kind of embarrassing questions. Do they have painful, bloody bowel movements? Do they have frothy urine? Do they have pets at home? Have they been in contact with a cat? Did they go camping and tick bites? If they had rashes in strange places? Because the eyes and the neurologic system can be impacted by so many different conditions, and you don't know it's important until you've asked.
Wow. Well, I want to go back to my genetic optic neuropathy and Wolfram syndrome. And I'm just curious, how did you learn about such a rare disease? How did you learn about Wolfram? Was it in school? Was it in your practice? Was it something you read? I doubt that, but how did you learn?
Yeah, I don't remember if we talked about Wolfram's in medical school. There might have been 30 seconds on it if there was.
If any.
Certainly in residency, we're supposed to try and learn everything there is to know about ophthalmology in the 3 years of ophthalmology residency, or at least have heard about it and know where to go look it up if you need a refresher. There was not a lot of time spent on it in residency. During my neuro-ophthalmology fellowship, you really dive deep into neuro-ophthalmology and recognize that in 1 year it's impossible to see everything there is in neuro-ophthalmology and impossible to learn everything. So you read and read and read, and then I actually did a second fellowship in Iowa. In medical retina, and we spent about 20% of the time there doing genetic conditions, and those most of that was for retinal disease, but there's some overlap, and so we learn about it there, some overlap there as well. And then when you go to medical conferences, we talk with colleagues and we'll listen to lectures on rare conditions or new developments. I don't remember if it was before or after we met, but I actually wrote a book chapter on genetic optic neuropathies. And while Wolfram's is certainly rare, it's one of our 3 archetypes of genetic optic neuropathies.
Oh, wow.
Because most people don't know this, but in your genes, everybody knows that you have, well, not everybody knows. I get in kindergarten, right? They tell everybody you get 23 pairs of chromosomes, one from mom and one from dad. There's actually a third set of genes that everybody has, and these ones only come from mom. And it doesn't matter if you're a boy or girl, they only come from mom, and they're called the mitochondrial genome. And the mitochondria in the cells are what's responsible for generating energy. And you can actually track lineages via the mitochondrial DNA
Mm.
going way back. And every time somebody shows up saying they're one of the lost Romanovs, they can go and check their mitochondrial DNA, and they say, nope, you're not a maternal descendant of the Romanovs. I'm sorry, you don't get to be the Empress of Russia. Um, and one of the most common genetic optic neuropathies called Leber's hereditary optic
Right.
neuropathy is a mitochondrial condition, and so that's one of the archetypes. And then up there for the top two is what's called dominant optic atrophy. And in the genes you get that are split between mom and dad, because everybody has two copies, there are some conditions that are called dominant, where if you have one abnormal copy of the gene, then you have the condition, and that's why it's called dominant, because that gene kind of dominates the
Rules
condition.
over. Yeah.
And that's what dominant optic atrophy is in the OPA1 gene. And if you have one copy of OPA1, you have it. And so there's a strong family history in dominant, because that you had to get that from one of your parents, and then that means they also had to have the condition, and they got it from one of their parents. And half of any of the kids in a generation are going to have that condition. So big family
Wow.
history. It's really easy to find dominant genes when you're looking for them. Wolfram's is the most common, even though it's super rare, of what's called autosomal recessive, which means it takes two abnormal copies, one from mom and one from dad. Now, mom and dad are usually normal because they have one normal copy and one abnormal copy, and each of the kids has a 25% chance of getting both the abnormal copies. So much rarer in the family, and you don't always have a family history. But there are other genes that can cause autosomal recessive disease, but Wolfram's is the one we know the most about because it has all these other features with it, and so it's easier to identify. When it's only causing an optic nerve problem and you're the only person in the family with it, it's so much harder to even recognize that it's a genetic problem, because nobody
Right.
else has it and you don't have any other manifestations.
Wow. Have you diagnosed many rare diseases in your practice?
I guess it depends on what you're using as a cutoff for rare. Is 1 in 10,000 rare? Is 1 in 50,000 rare? Is 1 in 100,000 rare? Things like the retina side has for genetic diseases is much more common. An inherited retinopathy called retinitis pigmentosa happens in about 1 in 4,000 people. And Stargard's macular dystrophy is about 1 in 10,000 people, but that's a one gene condition, as opposed to the retinitis pigmentosa is there might be 100 to 200 genes that can cause it, but they all look very similar, so they get grouped together for 1 in 4,000. A single gene is much rarer for that, and that's probably 1 in 100,000 for any single gene to cause retinitis pigmentosa. So I think being at Johns Hopkins and the Wilmer Eye Institute, we see a lot of rare things. And it's it's one of the things that keeps the job interesting, and getting to help patients and help them on their journey is very rewarding. And that's one of the things I love about being at Johns Hopkins, as well as getting to work with wonderful colleagues who can say, hey, I'm not sure this is what we think it is. Can you take a look? And just the collaborative effort is really a wonderful spirit to be a part of.
Wow. That's amazing. Thank you for all you do. It makes me wonder, though, are most rare things genetic?
A lot of medicine, we have learned over time and been able to identify conditions, and the human genome is just one of those mysteries that only recently we're really starting to unravel.
Okay.
The Human Genome Project, was finished in the early 2000s, I believe, and that was the first time we were able to sequence the entire human genome, and that was from one person. And since then, and that took, a decade or more time. Now we can, sequence an entire person's genome in a few weeks if you have an extra $1,000 laying around. Um, but there's so much what we call normal variation out there. My genome's a little bit different than your genome, Cathy, and your genome's a little bit different than Beth's genome, unless you guys are identical twins that I'm not able to recognize. And that's what makes us each a little bit different, even though our genomes are very close. We're like, 99% the same. But those little changes in the genome are what makes us individuals, and trying to recognize, is this little difference a problem, or is that just normal for you? And so there's still a lot that we're learning, and there are patients who I'm convinced have a genetic optic neuropathy, and we've looked through the entire genome and we haven't been able to
Been
find
able
it
to
yet.
find one.
So there's a lot we're still learning about. There are certainly rare conditions that are not genetic. You can have super rare infections. The news loves to talk about the teenagers who jumped in a lake in Florida and got
Yes.
an amoeba in
Right.
their brain. I mean, that's
Yes.
super rare, right?
Yes.
That's like 1 or 2 people a year in the world. So,
Uh-huh.
that's, we're talking like 1 in 7 billion. There are super rare autoimmune conditions, although maybe those have a genetic predisposition, and they're one of the genes that's supposed to help with your immune system is a little bit off, and then you're prone to autoimmune diseases. Um, so I think genetics is certainly a very common cause of super rare conditions, not the only cause. And it may be more of a cause than we recognize. It may be that some patients who develop some kind of toxic injury, that one of their genes made them more susceptible and they were not able to recover from it. Like
Hmm.
people who drink a lot, who have alcohol addiction, some people develop vision loss from that, some people don't.
Wow.
And maybe it's the genes that separate those two types of people.
Most of your patients adults?
The vast majority are adults. We have some very phenomenal pediatric ophthalmologists at the
I
Wilmer
was
Eye
going to ask you
Institute.
if you see children. Do you
And
see children, or do you refer them to a pediatric specialist?
I will see them if somebody with pediatric expertise saw them and said, I really think you need to see a neuro-ophthalmologist, or they
Uh-huh.
have a clear neuro-ophthalmologic problem. If they had like a brain tumor, and they need to see me for that, or we know they had some type of inflammation in their brain, like they had pediatric multiple sclerosis or something else, and
Mm.
they need my type of expertise, then I will. M Most pediatric eye conditions, even if we're not 100% sure what they are yet, are the pediatric ophthalmologists are so much better at
Uh-huh.
evaluating kids, because they as we've talked about, that history and being able to really communicate with the patient is so important, and that's really hard with kids, and they're also not great at sitting still for an eye exam. And so the pediatric ophthalmologist, because they practice that and do that day in and day out about, figuring out what's the most important part of the exam I need to do right now, and let's do that while we can do it, and then everything else, we'll fill in as we can. And sometimes you even have to take the children to the operating room and give them a little anesthesia just to do an adequate eye exam. And
Uh,
so if it's a pediatric thing, I usually have the pediatric folks see it, unless they say, "Hey, Dr. Carey, can you help with this case?" And then, of course, the answer is yes.
that's good to know. That's
Yeah.
good to know.
Absolutely.
I, I guess we are especially interested in Wolfram because my co-host has it, and so I wondered about your research and what you hope to accomplish.
What a wonderful question. Wolfram's is a little bit different than some of our other eye conditions because it has so many manifestations outside of the eye. And so uh, when we that really takes a multidisciplinary approach, working with neurologists and endocrinologists for caring for the patients, but also when we're trying to come up with new types of treatments and looking at experimental studies. One of the challenges with a rare condition like Wolfram's is we know what typical Wolfram's looks like. But as we were talking about before, how my DNA is a little bit different than Cathy's DNA and a little bit different than Beth's DNA, we're not really sure if we know what everybody's Wolfram's looks like. And so one of the important things is to try and evaluate as many people that we can who have Wolfram's to understand what's that variation, and so that we're better at figuring out if somebody has Wolfram sooner, so we can get them treatment sooner for the things we already have treatment for. And B, also trying to figure out what are different people's visual impairments and visual needs, so that we can tailor that for the patient and also try to give them an idea of what their visual future may look like. A lot of Wolfram's patients have really severe vision impairment in childhood, and so they need very early vision and education-based interventions so that they can get the education they need, because the education of a blind child is very different than everybody else. And we know that education is so important for long-term health, socioeconomic status, happiness, how much income you can earn. All of that is so tied together, and we don't want to disadvantage any child. And if we miss that early and they've fallen behind in school, it's really hard to catch up, because the children's brain is such a sponge. So much learning happens even before they get to school. I mean, think about it, right? You had to learn to walk, you had to learn to talk. You probably even start learning to read a little bit before you're even in school. And so trying to really help with that. But some people, the vision impairment happens later, teen years, 20s, maybe it's much later, and just trying to get an understanding of what that kind of variety is out there for Wolfram's is really important. Also, some of the research that I'm particularly interested in Wolfram's is trying to collect as many patients as we can who might have been seen in Hopkins or be within the Hopkins geographic network that we could recruit to do a comprehensive evaluations of their vision, their optic nerve, their retina, to see what kind of variety exists there, and to kind of compare, well, this person may be 5 and this person might be 20 and this person might be 50, and see if there's changes that we could predict, and then as time goes on, follow those patients to better understand how that would change. And then the other thing that we are finding with multi-system genetic conditions is that a lot of times when a new treatment comes out, either a medication to try and modify the gene's function or a new genetic treatment, is that the eye, because we have all these wonderful tools that we talked about, like the OCT and the visual field and color vision, and we can look inside, is a wonderful way to monitor that. And we're finding that with things like Alzheimer's dementia and Parkinson's and other genetic conditions, that there are changes in the eye that we can monitor, and for diseases getting worse. And as new treatments come out, we're hoping that those same techniques will allow us to see if there's treatment responses to treatment and improvement.
We have spoken to some parents of children with Wolfram's, and their children are losing their sight. It is such a difficult disease and a difficult conversation. And we've raised awareness, and you're doing such good work. For our listeners, I wonder if you could tell us how they could get involved and support your research.
That is a wonderful question. We do have some very wonderful dedicated staff members at Johns Hopkins and the Wilmer Eye Institute that help with development, and people who are interested in gift giving. And every little bit helps, whether it's a couple dollars to help fund medical student research into the field and get new those young clinicians interested in the field, which is so important for the future. Or if it's something that they want to help fund part of a research project or help fund a research fellowship. All of those things are so important. And then one of the most important things is also helping us to find and see those patients. If you have Wolfram's, or somebody who has Wolfram's, not only would we be interested in trying to help them as a patient, but also we learn a lot from our patients, and having that opportunity to learn from those patients would be really helpful.
Very good.
Wonderful. Wow. How does the future look for rare disease and genetic optic neuropathies in particular, since we were talking Wolfram?
Yeah, I think the good news is, as we talked a little bit about, the Human Genome Project and genetics is kind of a newer field. We've known about genes for a while, that they were hypothesized, and then when we developed the X-ray technology, Watson and Crick were able to identify the double helix in DNA, and then we were able to show that's where the genes are, and that's how we pass down traits and encode proteins. There is a lot of research into genetics, and we have some wonderful researchers at Johns Hopkins who are working on trying to grow new ganglion cells, which are the cells that send their cables that become the optic nerves, and working on stem cells. One of the challenges with optic nerves is because it doesn't just stay in the retina, it has to go and travel to the brain. There are doctors at other institutions who are working on ways to stimulate and guide those optic nerves from the retina to grow back towards the brain. And some of that is using electromagnetic pulses to try and help grow that. And other doctors are working on growth factors to help maintain the health of the ganglion cells after they get transplanted. And we're doing some of that work at Johns Hopkins in mice currently. And so that's kind of like the genetic stem cells. There are other doctors who are working on various more traditional kind of pharmacology medications that may help to supplement the health and function of optic nerves to preserve what's currently functioning and to help stabilize vision, prevent further visual decline. So there's a lot of different efforts that are being made at a lot of wonderful institutions with really smart people, with Johns Hopkins and the Wilmer Eye Institute certainly among them. It's not something that is going to be an easy fix, and so it does take all of those folks working at it. But we're making more progress than we've ever had before, and I think the fact that we're able to demonstrate that in certain animals we can implant new ganglion cells and grow optic nerves is just mind-blowing at this point in time.
Would be wonderful. That would
Incredible.
be wonderful. That
Incredible.
would be wonderful. For all the glaucoma patients out there, this would be
as
a
well.
prayer.
Yeah.
Absolutely. Well, in closing, Dr. Carey, is there any advice you'd like to give our audience today?
I think the advice that I would give, to patients out there is first, if you notice a change in your vision and your vision seems off, don't blow it off. Go see your eye doctor. And if your eye doctor says, I'm not really sure what this is, sometimes you have to advocate for yourself, and probably the best question after that would be to say, is there somebody maybe you could recommend that I should see that might be able to do other testing or have other thoughts? And I think most doctors would take that question and say, I do know somebody, and be able to help. We didn't specifically focus on this today. There are some things in the vision that could be an emergency, like sudden onset of vision loss in one or both eyes, or sudden onset of double vision, and those could be signs of strokes. And that might be something you'd want to go to the emergency room for, because that could be a sign of a serious brain issue presenting as a vision problem. It's not the kind of thing where you say, let's go to sleep and see what it's like in the morning. I guess those are the two biggest pieces of advice that I would have for any listeners.
It's amazing how much of our health is connected to our eyesight. I mean, just from listening to you today, it's just remarkably important to make those connections, and for patients to understand that one thing may be linked to something else that you never imagined. And I can't thank you enough. This has been an incredibly insightful and educational session. And thank you for being a guest here today. It Happened to Me is just so thrilled to have you on. And you've really helped to educate and enlighten our audience, as I was saying, but about neuro-ophthalmology and optic neuropathies, rare diseases, genetics. Thank you, thank you, thank you. It's just been a wonderful session. Thank you.
Well, it's been such a pleasure to be on here. Thank you for inviting me and allowing me to talk about some of these topics I'm quite passionate about. So it's always fun to share.
Thank you for everything you do.
Thank you.
Thank you for listening to this episode of It Happened to Me. We encourage you to learn more at ithappenedtomepod.com. Please use the contact form on our website to submit your guest suggestions, comments, questions, ideas, and feedback for the show. You can also email us directly at ithappenedtomepod@gmail.com. We would really appreciate it if you can leave us a 5-star rating and review on your podcast app like Apple or Spotify. This helps others in the rare disease and medical challenge community find us. It Happened to Me is created and hosted by Cathy Gildenhorn and Beth Glassman. I'm Kira Dineen from DNA Today, and I serve as our executive producer and marketing lead. Amanda Andrioli is our associate producer. Ashlyn Anokian is our graphic designer. And remember, it happened to me. I'm not alone, and neither are you. Thanks for watching DNA Today. To access all of our episodes, head over to dnatoday.com. We also have a lot of bonus content on there that you can enjoy. If you have any questions, comments, suggestions, guest pitches, you name it, send them in to info@dnatoday.com. We'd also really appreciate if you could take a moment to rate and review the podcast on Apple, Spotify, wherever you listen to the show. It really helps more nerds like yourself find the show. Also, if you like giveaways and other ways to connect with us, I recommend following us on social. We're at DNA Today Podcast. We also have a Patreon if you want to be the most level involved in the show. That's also at DNA Today Podcast. Thank you so much for listening and watching. Join us next time to learn and discover new advances in the world of genetics.
We're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.